All right. So what we were planning to do through this series of like lectures, we'll talk about like just basic of mechanical ventilation at the beginnings, and we'll talk about like the waves of mechanical ventilation. We'll talk about like things are most probably easy for you, like how we do oxygenation, how we do ventilation, mechanical ventilation, and like the names of everything in mechanical ventilation. So like how to calculate the resistance, how to calculate the compliance. But it's very easy to read all of these things without like interpreting in your mind. So what we would like to do after like these like 5 or 6 series of like lectures, you will be able to stand in front of the mechanical ventilation. Even if you don't know exactly what's going on, you know at least what's wrong with the patient and how can you like synchronize the machine with the patient. Or you can grab one of your attending, hey, I think this is going on, instead of like, hey, he is having dysynchrony, this patient having dysynchrony with the patient, and we will just like sedate him more. Because like that's what I see like as an answer from like most of the residents and first years fellow, like even for myself, like when I was first year fellow, like, oh yeah, he has the synchrony and it looks like he's fighting the vent. Like as a pulmonologist, I don't want you to hear, like I don't want to hear this from you, like he's fighting the vent. There's nothing called he's fighting the vent. Fighting the vent for the nurse, fighting the vent for resident, but for you guys, patient has this synchrony and we will do this and this, or I have done this and this and it did not work, so the only option is sedation. Okay, so we'll start with a quick case. And as usual, so we have a 56-year-old patient who's active smoker with a past medical history significant for COPD, Gold D, and he had recurrent exacerbation. And present to the ED, he was complaining of dyspnea as any exacerbation symptoms. And they did workup. They found that the patient is a little bit desaturating, like he's 89%, but that's on non-rebreather. They did an ABG, showed his PO2 is significantly low on non-rebreather, like 56. So PCO2 was significantly high. So I can call this patient acute hypoxic hypercapnic respiratory failure. They did a chest X-ray, and you can tell me, what do you see in chest X-ray? What do you see, Hatab, in chest X-ray?
Right upper lung infiltrate, slightly pneumonia. Also, there is some haziness on the left side as well, on the lateral left upper lung side.
Okay, so, and you said it's most likely pneumonia. Why is that?
Well, it's because...
Could it be cancer?
Can be.
Yeah, this
Okay.
could be a collapsed lung. I don't know, this is black line on the...
Okay, so just like quick notes about chest X-ray. When you see like you can just say, like, always think that as you are a radiologist, and we'll talk about that like in Friday. But this is an airspace disease affecting the right upper lobe of the lung, and with bilateral airspace disease more in the right side comparing to the left side, and then you put your differential diagnosis, which pneumonia, one of these diagnoses. So they did the CT scan, and the CT scan showed what we call this. Air bronchogram.
Yeah.
Hepatization. He's doing ultrasound.
Consolidation.
Consolidation, that's right. So this is a why didn't say ground glass?
Because it's one consistency, like ground glass usually is...
Raul, you were planning to say something.
Yeah.
You can see the back of it.
You cannot see behind it.
Yeah.
That's a consolidation. If you can see behind it, that's ground glass. And you said air bronchogram, which you are right. All right, so we'll start about this lecture today. So, or it has to be like discussion, but like if you have any questions, stop me anytime. So let's talk about like quick review about our normal breathing. Because if you understand our normal breathing, you understand them. Yes?
Sorry to interrupt. Is there any way we can record it?
It is.
Mina requested that.
It is recorded.
Okay, good. Okay.
You have the associate program director here. Come on. You need to understand the normal breathing mechanism to understand the abnormal and to understand the mechanical ventilation, because I can come and say, hey, this is PEEP, FiO2, tidal volume, 6 ml per kg, and all that stuff, and you can memorize it, and that's it, and you don't understand anything behind it. But the first guy who like decided about mechanical ventilation, he looked at the normal breathing of the patient and he tried his best to just mimic exactly the same to like, but just to help the patient. So normally when we breathe, that's very easy, we shouldn't stay a long time in this slide. So when we breathe normally, like the expiration is passive, like, but inspiration that we need power for that, is that right? So we take a deep breath by contracting our diaphragm, and our diaphragm will go down with contraction. So so our diaphragm will go down with contraction. When our diaphragm goes down, what will happen to the pressure inside the pleural cavity? It will go down, is that right? So it's like from -5 to -8. Do you know what's the -5, -8 compared to what? Always like we see it, -5, atmospheric pressure. So it's 5 points below the atmospheric pressure or 8 points below the atmospheric pressure. So you can, like you can say the atmospheric is 760 and this is 755, okay? So that's like it's 5 points below the atmospheric pressure, and then when I have a deep breath, it will be like -8. And that's because I have decrease in the pressure around the alveoli, the tension around the alveoli will decrease, and then the pressure outside is higher compared to the pressure inside, is that right? And usually the pressure will go according to pressure gradient, is that right? So the pressure outside is high, pressure inside is lower, so the air flow will go from outside to inside, is that right? So we had to have a muscle, we had to have a changes in pleural pressure, we had to have a pressure difference between outside and inside to push the flow inside the lung, is that right? And all of these words that I'm saying, it's exactly what we do with mechanical ventilation, is that right? So if we breathe, so the pressure inside alveoli, we call it what? Anyone?
Atmospheric.
Inside the alveoli.
Inside it.
Yeah. Anyone?
It's here.
Interpulmonary pressure. Okay? And so the pressure inside the pleura is the interpleural pressure. So you are a pulmonologist, that's how you talk when you talk to someone else. If you come to Dr. Al-Jasmi and say, hey, this patient transpulmonary pressure is 10. So he knows that you know what you're saying and what you're talking about. If you come like, I think the pressure inside is high, the pressure outside, he's like big and you know he's morbidly obese, I think we're gonna paralyze him. That's not, so always try to use these terms to stay in your mind. So what's the difference between, so the difference between the intra-alveolar pressure or the intrapulmonary pressure with the intrapleural pressure, that's what we call the transpulmonary pressure. Okay, when I say transpulmonary pressure is the difference between the alveoli and outside. Why it's important to know that? Because we said the pressure outside went down and the tension around the alveoli went down and the pressure inside the alveoli went down. That's what let the air comes from outside to my lung. Okay? So I took a deep breath, pressure went down, there's volume increased, pressure went down to -8, flow will come from out to inside. And that's what we see usually in mechanical ventilation, is that right? And that's the real life thing. So that's pressure, that's flow, and this is volume, okay? So the pressure, the air, let's start with the flow. The air came from the higher pressure to the lower pressure, is that right? And it came from outside to inside. And at the beginning, because the pressure is big different in the pressure, it came so fast, is that right? So it went up like this. And then because it started to be, the pressure inside your lung start to be getting closer to what it has to be at the end of expiration or to the outside, then the flow start like going down slowly, which we call this deceleration. That's our normal breathing. I'm not talking about mechanical ventilation, okay? Our normal breathing. And to push that flow inside the lung, you had to have a different in pressure, is that right? And we can see this the pressure. So this is the beginning of pressure till I reach the peak of this pressure. So that's the peak of it. And by doing this, my lung was able to have volume. So different in pressure gave me volume inside my lung. And this is the volume. So that's during inspiration. Okay? So the flow, to have a flow from here to here, flow of air or flow of oxygen, from here to here, you need to have different in what?
Pressure.
Pressure, that's right. So to have a flow, I need to have different in pressure. And what else will affect your flow? Resistance. If there is a narrowing in your airway, if there is like a blockage in your airway, that's what we call, so flow equal the difference in pressure divided by resistance. So that's flow. We're still not talking about mechanical ventilation. We are breathing normally. All right. So now I told you take a deep breath, Al-Tabi. He took a deep breath. Hold it. Is there any flow goes in right now?
No.
What we call this? Is it dynamic or static now, your lung?
Static.
Static. So there's no flow goes in right now. Is that right? No flow. He's like static. And I told him to hold your breath at the end of what? Inspiration. What we call that?
Inspiratory hold, which is...
That's right. We don't call it plateau pressure. I didn't say what's the name of that pressure. What's the name of that mechanism? Inspiratory hold. I asked you to do inspiratory hold. Okay? So that's what I asked Hatabi. He did that. If I look at the pressure inside his lung, what we call that pressure? That's the plateau pressure. So that's the plateau pressure. And I will talk more about it later. So the plateau pressure, is it dynamic pressure or static pressure? Static pressure. So does the resistance in your airway affect the plateau pressure or not? I close the airway. Should not. What do you think?
I think it doesn't.
Okay, why? What's your rationale? Feel free to say anything. That's the time when you make mistakes.
Oh, because there is no any flow actually coming
That's
in.
right. There's no flow comes in. So that does not affect. But if I'm sitting in here on top of your alveoli and I'm trying to push against this pressure, will that affect it?
Yes.
So what we call if something will prevent the alveoli from stretching.
Compliance.
That compliance. So elastance and compliance, that's the two things that can affect plateau pressure. But so you understand now, not just memorizing, okay? So then I asked the patient to exhale. What will happen? It's passive. His time, his brain, the center told him hey, that's enough time for inhalation. So what did we do? We did oxygen from outside. What's the FiO2 now? We're talking.
21.
21. Good. So I have oxygen from outside. I have pressure difference from outside and inside. I have a flow, and I have working muscles, and I have what do you call normal resistance and compliance. Okay, and then I ask the patient to breathe out. When the patient breathe out, it's just the time which respiratory rate is done for the inspiration. His diaphragm went back to the normal size, his pressure inside his pleura went back to the normal, and the pressure inside his alveoli, it's the highest now, and then the pressure difference will be the opposite, so it will go out from in out, okay? So we said this is inspiration, this is inspiration, this is inspiration, and this period, this pause, we did it. We asked him to stop breathing, is that right? And then the air goes out, and this is expiration. So this is inspiration, and this is expiration. That's normal. I cannot control anything of this. That's the patient breathing by himself. And so what do we have to have a good oxygenation and good ventilation? 21% from the air. We have pressure gradient between the positive pressure and the pressure inside the alveoli. And we have flow from outside to inside and the opposite. And that different in pressure gave us a volume. And we have our brain tell us what's the time for breathing. Is that right? Anything difficult now? Easy? Normal? Any questions? No? Good.
PIP.
Forget about PEEP.
Okay.
All right? Just pressure difference.
Okay.
I want you to understand there is a pressure difference from outside and inside. Yes?
Just the flow with the expiration, it became negative, then naturalized, became zero again.
Why is that?
Yeah.
So
I mean, when the diaphragm is going up, the flow.
So when diaphragm going up at the beginning, the pressure inside the alveoli was so high, is that right?
Yes. I mean.
It was high comparing to outside.
Yes.
So that's why at the beginning you're gonna push it very quickly. As when we take the air in, At the beginning, we pushed it in very quickly, and then because it's equalizing, it started going slowly down.
Yeah.
And then during expiration, it went down to the negative during expiration, and then it will go down slowly till we have equalize again, and then we have inspiration, and it's like a circle.
Okay.
Did I answer your question or not?
Yeah.
Sure?
Thank you. Yeah.
All right. So they did this. The Iron Man. Not the Iron Man, the new one, the TV show. I mean the series. So iron lung. Iron lung. So one of the scientists said, okay, I can do exactly the same how the lung does and do the negative pressure comparing to atmospheric pressure to help the patient. Okay, good. So what are you going to do? I do exactly the same, more negative pressure. Oh, you're sick, you cannot breathe by yourself. Okay, I will increase the negativity in this machine to make your lung cavity from outside, it's more negative to pull air in. So your head is out, and you can talk, you can do everything, but you feel the support because there's a big difference in pressure. But imagine that's our ICU, like with all of this equipment, and this is the mechanical ventilation with all the bed source and all of that stuff. So they decided to invent more and more and more, and they reached this mechanical ventilation, that small machine. What's the difference between this and this? Except the size, so other things. In here, pressure always negative, is that right? In here, pressure always positive. There is no negative pressure. The machine is the one is pushing pressure inside the lung. It's always positive. Whatever it is, volume control, any name, it's a positive pressure. Okay? All right. So that's an easy question. Let's start with the first here. So oxygenation. What are the two parameters you can change to help oxygenation?
FiO2.
And PEEP. Okay, good. And are the two parameters you do for ventilation?
Tidal volume and respiratory rate.
Okay, if I can make the question a little bit difficult. What else you can do? So ventilation depends on respiratory rate and tidal volume.
For what?
Minute ventilation. So what's the definition of minute ventilation? What is
Tidal
the
volume
equation?
times the respiratory rate.
That's right. So, all right. Raul knows.
Increase the eye time.
Yeah.
You mean to
So,
increase the ventilation?
me and Hatabi are twins. Okay? We are twins. We have exactly the same everything, except I'm breathing 25 breath per minute. Okay? And my tidal volume is 300. And Hatabi breathing 15 breath per minute, and his tidal volume is 500. Is there a difference between our minute ventilation? Do the math. 25 times 300 is...
There is difference.
1500.
I'm very bad at math.
7,500.
7,500, okay, 15 times 500.
It's going to be the same.
Oh, okay, so I didn't answer. The same minute ventilation, is that right?
Yeah.
Okay, the same, don't be scared.
There is a dead space.
I don't know, to be honest.
What's that?
Dead space.
Okay, dead space. We are twins. My dead space is 150, his dead space is 150. Is there a difference?
Yeah, it should be because 150 minus 300 will be 150, the actual
Awesome.
change.
Good. So minute ventilation is affected by the dead space. If you have a high dead space, or if you have a normal dead space, but your tidal volume change, that will affect your minute ventilation. So as a pulmonologist, as a resident, you know that tidal volume times respiratory rate give you minute ventilation. But always put in your mind, what's the lung disease? What's the mechanics in his lung? What's going on inside his lung? So that's why always put in your mind, there's a dead space that you need to put in the calculation. Dead space for the patient was normal before he came to the hospital, but he might have a pneumonia like this patient, so that his dead space is not normal. Is that right? So that's why we do a lot of ABGs, and we look at the PCO2 and trying to calculate our minute ventilation to find what should we do to the tidal volume or respiratory rate to increase our ventilation, okay? But we cannot change the dead space, except if the patient has PE, we can fix the PE. If the patient has pneumonia, we can try to fix the pneumonia. Or if the patient has severe atelectasis, we can give pressure with mechanical ventilation, and we can do what? It might increase the dead space, decrease the dead space, proning as well, okay? But just always put it in your mind. All right, so that's your patient. The patient that you admitted, Hattabi. You admit him and you start him in mechanical ventilation. And that's his mechanical ventilation. So Dr. Jasmine came to you and he said, hey, did you start the patient, he's calling you over the phone. Did you start the patient in mechanical ventilation? Yes, I started him in mechanical ventilation. How is he doing? He's doing good, except like his FI2 is 100%. And which, to be honest, I have heard that a lot. Like, yeah, he's doing good. His saturation is 94%. Okay, what's the setting? He's in 100% FI2. All right, it's not good. But 100% PEEP of 5, respiratory rate of 28, tidal volume of 520. That's your patient height and weight. And that's what the machine gives you on the side, like respiratory rate of the patient 28, so exactly the same. The patient I to E ratio 1 to 1.2. His tidal volume inspiratory is 520. Tidal volume expiratory is 500. His minute ventilation is 14. And that's peak pressure, plateau pressure, PEEP, and flow. So you have everything in this mechanical ventilation. So what's going on? So someone read for me like the first, what's the first wave? Well, like the first one in the top. What's that?
Pressure.
It's the pressure.
All right, does that tell you anything?
Is it back to
It is
zero?
a
It's not-
resistance.
it's not
I
going
think
back
the
to
pressure
zero.
seems high.
It's possible.
Yeah.
So it's not back to zero,
Yeah.
okay? Should it be back to zero? What do you think?
Sure, but like,
What's that?
but you mean like so it's inspiratory hold what we were doing. That's the
We are not doing any, that's the mechanical ventilation actively and no one touching. I'm not touching. This is the inspiratory. I can touch it, but I'm not touching. Does it go to zero, Raru? No, not Raru. Yeah, you are the same year, is that right?
there's
So Raru.
it should not be back to zero.
It is a peep, so.
That's
Yeah,
right.
there is a
It
peak.
will not
Should
go to
be-
zero, except if this is zero.
Yeah.
Does it go to negative?
But the flow should go back to zero.
That's right.
Yeah.
Does it go to negative, the pressure? Can it go to negative?
Never.
Never.
No.
Wow, never. Kareem. Raru.
Inside the, the pressure inside the lungs should never go back to zero.
I'm asking you, like, could this go to negative?
Or negative. I don't think.
No.
Anthony. Raru. Come on, guys.
It is if it's pathological, right? I mean, I've never
That's
seen.
the way how to answer, like, it depends.
Is there any leak?
So, no.
No, it should not be.
Oh, sorry. So, it depends on your patient. So what's this in the beginning of each?
It's the beginning of the breath when the patient triggered the ventilation.
So the patient triggered the ventilation. So, and it brought it less than the PEEP, is that right? So it depends on how your patient is synchronous with the vent. If your patient had like what we used to call flow starvation, so he's like needs more flow and he's no more like volume, he will try to do more, is that right? He try to bring that more negative, trying to do his best. But the machine itself, it's always giving positive pressure. But if the patient has what we call one of the dysynchrony, which is inspiratory work shifting, which used to flow starvation, which is, we'll talk more about it, it can go down negative, okay? But Anthony said something about the flow. Do you see anything abnormal in the flow, Anthony?
It seems that there is
Okay, so let's understand about these waves.
some air trapping.
We'll
there.
talk about the pressure wave. Pressure wave. So we said to breathe in and out, what we have, Like normally, we're breathing in and out and bring volume in a normal person, no mechanical ventilation.
Different pressure.
Oh.
Different pressure.
Different pressure. So usually the pressure starts slowly, start fast and then slowly till it reaches the peak. Is that right? And that's what we call the positive inspiratory pressure or the peak pressure. And the beginning of here, this one, what can increase this, make it like to here? So I have pressure pushing inside the airway.
Airway resistance.
Airway resistance. So if you have resistance, that will go up. Is that right? If you have resistance, that can be like this. Is that right? If you have resistance. All right. So the air goes in, dynamic or static, we said? Dynamic. Okay, so the air goes in, and that will give us
Flow.
here. All right, so I said when the air goes in and there's a dynamic pressure, there's dynamic flow, that's the peak pressure. It's the pressure required to push the air inside your alveoli over the resistance in the airway and it reaches the alveoli, and it does affect by what else? So the resistance inside the airway. When I reach the alveoli, do I need the pressure to keep it open during inspiration, during dynamic? If I'm a big guy, like I have a lot of weight on my chest,
Compliance.
compliance. So elasticity and compliance can affect it as well. So resistance, elasticity, and compliance can affect the dynamic. So then I asked Hatabi to stop breathing. He took a deep breath in and asked him to stop breathing. Is that right? What happened when he stopped breathing? We said, what's the pressure? Static pressure. There's nothing moving right now. And why we need to know that, we said? Because we need to take what from our equation? The resistance.
The resistance.
Okay. So when I asked him to stop breathing, that's the plateau pressure. And I asked, that's the pressure required to keep the lung open and overcome the compliance of the alveoli or around the alveoli to keep it open. During what? During inspiration. We are not talking about expiration. So pressure goes up to the peak, and then now it's going down. But if I ask him to hold his breath, that's what I have done by myself. I'm the one who touched the mechanical ventilation, and I did the inspiratory pose, and that's what will give me the plateau pressure. Okay? So if I have resistance like this, what will happen, we said?
Plateau pressure gonna go up.
Plateau or peak? Peak pressure. So our peak pressure went up. But my alveoli is exactly the same, and outside the alveoli is exactly the same. What will happen to the plateau pressure?
Same.
It's gonna go up.
Gonna go up.
Will not change.
It will not
Go
change.
down.
It will not change.
It will go down a little bit. So anyone give me a rationale?
Because
It
you
just-
have
It should not
I think
affect
it
the
should-
It should not affect. It should not be affected. It's like if there is no disease in the compliance and elasticity of the alveoli, then it should not, the plateau pressure should not be affected. So the peak will go higher because I have resistance, but the plateau should not be affected because plateau pressure is the pressure required to keep the alveoli open at the end of inspiration with a static flow. There's nothing going on, okay? So the peak is changing, the plateau is the same, so the peak went from here to here, and the whole resistance went up. So we'll talk more about it, but the difference between the peak and plateau, it can give me the resistance. So if it was normal and the peak was here, it's a big difference between this resistance and this resistance. So I can know what's exactly the resistance, and you can use it for a patient who has COPD or asthma, and you say like, yeah, I think I still need to do like more breathing treatment, or I need to paralyze the patient. You can calculate his resistance and know exactly what's going on with his lung mechanics. Do you need to? No, you don't have to. But as an academic and teaching-wise, you can look at it. Or if you reach the point that I think he needs to be paralyzed and his main problem is the resistance, so then you can calculate it. And we will talk about how to calculate it. All right. So, sorry. So if I compress this alveoli, or I prevent it from stretching, so that's increase in his compliance, is that right? What will happen to the peak pressure?
Gonna go up.
Up. Plateau pressure?
Up will go up.
Up. So why is that?
Because the resistance.
the resistance, it will not change the plateau pressure, but the compliance will increase the plateau pressure. And that's usually what will happen. So everything will go up. So if you calculate the resistance will be normal if there's no resistance problem. But the peak will go up, the plateau will go up, okay? And we'll talk about what's the difference and the normal difference. We talked about that. How we calculate plateau pressure? What should we do? What's maneuver? Inspiratory hold. So that will give you the plateau pressure. All right, we'll talk about compliance later. All right. So how to calculate the resistance? So we said the peak minus the plateau. Is that right? That's to calculate the resistance. What else that it has to be in the equation? Like, so changes in your peak and flow will change. What will change what? Do you remember the first slide when we said flow equal what?
Change in pressure divided by the resistance.
Okay, then the resistance is what?
Peak pressure minus plateau pressure.
No, you said flow equal change in pressure divided by the resistance. Is that right?
Mm-hmm.
And then the resistance is what?
Delta pressure over the flow.
That's right. So you have the difference, which is very easy. You like the peak flow, it's always there in the machine. It will give it to you. And the plateau, that you are the one who should do it and calculate it and make sure that you do it in the right way, and we'll talk about it. And then peak minus plateau divided by the flow. But so there is a trick that you can do and make your equation is very easy, and you don't need the flow. So you can change the flow to 60. Why is that? If you change the flow to 60, then because the flow, it's divided by how many seconds in 1 minute. So if they say the flow 50, then I have to change it 50 divided by 60. But if I change my flow from the beginning to 60, not all the mechanical ventilation you can do it like directly. Actually, all the mechanical ventilation you can do it, but not all of them you can do it directly. So I will talk how about the mechanism and how you do it, but I want you to memorize this. Peak minus plateau divided by flow equal resistance. What's the normal resistance? Less than 10 centimeter water. That's the normal resistance. If your patient have resistance of like 20, and the patient, you cannot, whenever I extubate my patient, he start like breathing tachypneic, and he's using his accessory muscles, and he failed extubation. Why he failed his extubation? Because your patient still have very high resistance, and he did not fix it. And that's why we use the Duoneb, we use the steroids, we use anything you can use to open his airway. Okay? So then compliance. So Raru or Anthony, do we use this method like compliance in our patient, ARDS patient, or is there something wrong in this equation? So compliance, I'm saying like it's the difference in volume divided by the difference in pressure. And the pressure is the peak minus the plateau.
Isn't it the loop, the compliance loop?
Like this equation, is it right or wrong for like when Dr. Zaid asked you, he said, hey, what's that patient compliance, that ARDS patient? Can you use this? And you tell him like his compliance?
I don't believe so, because sometimes the difference in the ARDS between the plateau pressure and the PIP is small. It does not give us the peak.
Peak minus what?
The peak minus the plateau is, like in these patients usually, is small. The
All right.
difference is smaller.
You're talking about respiratory system compliance or lung compliance in isolation?
Lung compliance. So this one, we have two different compliance.
In the RDS we do like lung injury protocol, low volume.
No, I mean like when I ask you, like this patient has ARDS. Hey Kareem, can you go and check his compliance and let me know what's his compliance by the mechanical ventilation?
Yeah.
So what do you do? What's the equation that you do?
I take it on the back.
Chicken in the fan. Oh my God.
To be honest,
So that's what I'm saying. I want you
to be honest with
from
you,
now, you need to understand how did you do it, okay?
I think there are two types of compliance.
Yes.
The dynamic
And?
the static.
Awesome. Good. So the dynamic means what do you want? What type of pressure?
The peak pressure.
Peak pressure. So you have to have a peak pressure for the dynamic compliance. Well done, Raro. So this is the dynamic. So this is when the air is going in, we can check the compliance, which is the peak pressure minus the plateau pressure. We used even static at the end of the dynamic. And the volume. So the volume that the machine is giving us, like what's the patient, not the volume that I'm giving to the patient, the volume that the patient doing. That's very important, guys. Not the volume you are giving. Because you might give 500.
it is controlled.
Yes, so it's controlled, but it's not always. Like PRVC is not controlled. You feel like, oh yeah, that's volume. It's not. So always look at the machine, what's the volume that the patient is making, okay? Peak pressure minus plateau pressure, okay? So that's dynamic compliance, okay? That's dynamic compliance. How I change it to static compliance? You should you should know how, because we talked about what's static pressure.
Hold the
Depression by end of inspiration.
Okay, so you need a plateau.
Plateau.
All right. What other static pressure do we have? PEEP, which is the pressure of what? At the end of expiration. Okay, so those are the static pressure. So the machine, what you do, when you ask the machine to do it for you, so that's right. Most of us, like we in the beginning, we do it like this. But it take the plateau pressure minus the PEEP pressure, and that's the static compliance. Plateau minus PEEP.
Okay.
Raru, bonus question. Plateau minus PEEP. What's the name of that pressure?
So driving pressure.
Awesome.
Okay.
Good. So the static compliance is the change in volume divided by the driving pressure. All right, and that's why when they did the study, they went back to look at the driving pressure, and they saw if your driving pressure less than 15, that's indicate that your mortality is less than the people that their driving pressure more than 18. All right. So what's this?
PEEP.
PEEP. That's right. So when you said it did not went back to zero, we are doing this. We are the one who's giving PEEP. So when you see the wave is not going back to zero, we are the one who's doing PEEP. And what's this? And it's not the same. What's the difference between this breath and this breath? Everyone, Anthony knows.
one from the mechanical ventilator, one triggered by vibration.
Good, awesome.
Assisted and complete.
So that's one. So that one, as I said, so this one, like you started the breath, but it's assisted by the mechanical ventilation. This one, it has been given by the mechanical ventilation completely. Because like maybe you are doing the rate, let's say 20 in the ARDS patient, so the patient, he doesn't want to breathe in here, but you gave him breath. And here the patient started the breath, and then you assisted his breath. Why I said you assisted his breath, it's not only the patient breath. That's very important wording, because you see like it's exactly the same. It's impossible that your patient has exactly the same pressures as the machine. But the machine, maybe the patient was trying to do like in here, and the machine pushed the rest of it. Okay, so that's assist his breathing. So this is very important to know. Why you need to know? If I'm paralyzing my patient, what should I see?
The first one.
Okay, so you can, the nurse came to you, hey, the train of 4 is 3 out of 4, which your target is 2 out of 4. And oh, yeah, okay, go up in the
He's breathing all.
so the train of 4, which is like, it's a different topic, but the patient, she's trying to tell you the patient is not fully paralyzed. But you looked at the mechanical ventilation and you see all of this, like all of it like this. Would you increase the dose or not? Because you are using the paralysis to just make sure that the patient is synchronous. So if the patient is doing good with less paralytics, that's good. You don't need that higher paralytics, okay? So you know which one is machine breath, patient breath, or patient assisted by machine breath. All right, we are back to our patient. So now we know about the pressure. What's this, Saddam?
Plateau.
Plateau pressure. What did you do to do this pressure?
Hold an inspirator.
So I pushed in this button, and then that give me this. Okay, what's this?
Peak pressure.
Okay. So what's the difference between this and this?
Resistance.
Resistance. Good. What's the difference between this, the plateau, and this, the PEEP?
Driving pressure.
Which, and if I add the volume, will give you what? What type of compliance?
Compliance.
You have to say static compliance. Okay? All right. So is that a normal peak?
No, that's high.
That's high. What's the normal peak?
30,
It's above 30.
30. Okay? That's right. So what's the normal plateau?
Less than 30.
25.
25, sorry.
So there's no normal plateau, but you don't want to have the plateau higher than a specific number, which is 35. Okay? But what's the difference between those two?
Resistance.
Resistance. And on top of what? You need what? You need the flow, is that right? So you have flow 50, you have this and this. So who can calculate what's the resistance in this patient, our COPD patient? So for time's sake, so 51, we did inspiratory hold, we got the plateau pressure. So we are calculating the resistance, and the resistance is 19. Is that normal?
No.
No, so that's a high resistance. So if you, Saddam, goes to Dr. Zaid or Dr. Jasmi, hey, this patient, he has a COPD and he's on Duaneb Q6 hours, and I gave him steroids oral. You know why? Because studies saying oral is exactly the same like IV. I gave him oral, and he's doing fine. And Dr. Zaid came to the machine, he did like some calculation and said, oh, no, the patient is not doing fine. He still have a lot of resistance. Give him IV. And then you'll start fighting, no, like steroid is giving oral, is the same. So he like always tried to rationale why the next step was done. So maybe I would like to increase steroid because I think he still needs anti-inflammatory or, you know what, this patient, I need to paralyze him. I need to get rid of this resistance and give time to the inhalers and steroids to start working with the inflammatory process. Okay? All right. I think we should stop in here. Is that right?
You put it back to the curve.
Sorry.
Like in your flow, on the flow time,
Yeah. So
when there is an inspiratory pause, it's not reflective on the
You're
flow
right.
because the flow.
yeah, it was difficult to build it
Oh,
up
okay.
with the
All right.
system.
And then the other thing on the flow, you have, an
I did it in purpose. I did it in I did it in purpose because
Oh, okay.
it will be.
Because that might be the reason for the high peak and the high plateau.
That's right.
Because of the O2P. Yeah.
So that's the next lecture about the flow. We talked about the pressure part. As Dr. Zed said, so this could be the reason of this. Okay? But we'll talk about, next one will be about PEEP, compliance, and flow wave. I think we should stop here, is that right? 51.
Oh, very good.
So you understand pressure wave? So now when you go to the ICU, you look at the pressure wave, you will sit and I know this part is this part is this. So you are a pulmonologist. So you need to understand the mechanical ventilation. All right, thank you. Thanks, Dr. Zaid and Dr.
Oh,
Jassim.
thank you.
Let me see if I can stop the recording. Is it okay?
Yeah, I'm done.
Where do you get your slides? You make them up?
Yeah, I make one.
Oh, okay.
That's why it was difficult.
Yeah, it's hard to,
Yes.
yeah.
Man, none of them are
Yes,
that.
yes, very good.
Thank you.
Yeah, I came around with the patient. No.
I can have the lecture send it to us. No.
It's recorded, so
Tomorrow part 2.
No, I mean the slide.
and everything.
And that should make
It was
you,
awesome.
thank you.
Appreciate it.
That should make you like understand mechanical ventilation.
Yeah, appreciate it.